This is Chapter 31, Care of the Patients with Infectious Respiratory Problems. Rhinitis is just your basic run-of-the-mill inflammation of your nasal mucosa. It can be described as hay fever or allergies. The allergic rhinitis part of it can be triggered by reactions to airborne allergens. Things that we see seasonally, certain times of the year, can make this worse. Also, dust, animal dander, foods. Some people have seafood allergies, different things along those lines that can cause the allergic rhinitis. The signs and symptoms that we see with it: headache, a lot of nasal irritation from blowing your nose so much, sneezing, nasal congestion, and then rhinorrhea, which is watery drainage from your nose, and you can have itchy, watery eyes with that. To help manage this particular rhinitis, you want to treat your symptoms. Okay, get those relieved, and then just basically with patient education, you want to teach them to use the medications that they are on. Some of those medications can be your antihistamines to help with the inflammation, decongestants to help thin out your secretions, antipyretics, which are like your Tylenol and Advil, and they can be given even if fever is present, sometimes when not present, just to help the aches and pains that may be present with that. Antibiotics if it is an infectious type process, and also vitamin C, zinc, things along those lines. Remember that your decongestants constrict your blood vessels, and they do help to increase the swelling that goes on there. Make sure your patients are drinking a good bit, at least 1 liter or 2 liters a day to help thin those secretions. Humidify the air. Sometimes just getting a home humidifier can help with that, or running a shower and sitting in the bathroom in a steamy bathroom after it's gotten hot. Make sure they're washing their hands, especially after blowing their noses or sneezing. Don't rub their eyes or touch their face. And then stay home from work if they're sick, especially if they're running a fever, or stay home from school if you have a child. Sinusitis is an inflammation of your sinus mucous membranes. A lot of times can be caused by the Streptococcus pneumoniae virus or the Haemophilus influenza, and it a lot of times is associated with the rhinitis itself. Things that may lead to sinusitis could be a deviated nasal septum, nasal polyps, air pollutants, the chronic use of cocaine, facial traumas, or dental infections. Any type of swelling can obstruct the flow of your secretions from the sinuses and then can lead to infection. Complications that you can have from your sinusitis can include cellulitis, abscesses, and meningitis. The nurse's diagnosis can be made on a patient's history, where they're hurting, signs and symptoms, sinus x-rays, sometimes a CT scan. If a patient has pure urine drainage, if it's green from either one or both of the nasal passages, then it could be a bacterial sinusitis, and sometimes they can be running a fever. So things that we can do to help with sinusitis: of course, antibiotics, analgesics like your Tylenol, Advil, decongestants, again, to help thin your secretions, steam humidifications, a nice warm washcloth over the sinus area. You can they make nasal saline to irrigate the systems out, and then of course increase your fluids. So pharyngitis is basically a sore throat. It's just a common inflammation of your mucous membranes. Strep throat can cause a lot of pharyngitis itself, which you can diagnose with the rapid strep test. You can have fever, and epiglottitis is a rare complication of strep throat, and epiglottitis is pretty severe. It can land you in the hospital. Realize that streptococcus, I'm sorry, acute pharyngitis can be caused by bacteria, viruses, other organisms, irritants like cigarette smoke, if a person is dehydrated, or alcohol use. Tonsillitis is an inflammation or infection of the tonsils and lymphatic systems. Most of the time, it can be cured with antibiotics. In multiple cases of tonsillitis, most physicians will go ahead and take the patient's tonsils out. It is a continuous airborne infection that usually is bacterial. Antibiotics for about 7 to 10 days. And like I said, it may need surgical intervention if the antibiotics do not clear it up. Most tonsillitis can occur in any age group, but it is less common in adults. It is contagious, if I did not say that before. And the bacteria that most commonly causes tonsillitis is strep. You can also have other viruses, and you see chronic tonsillitis with acute infections or recurrent infections that have not resolved from other antibiotic uses. Peritonsillar abscess, or PTA, is a complication of acute tonsillitis. It's an infection that can spread from the tonsil area down to the surrounding tissue, and it forms a big abscess. The most common cause of PTA, again, is streptococcus, and you still may have multiple organisms there as well. The symptoms that you will see are a collection of pus behind the tonsils, and that causes one-sided swelling, and you will have a deviation of your uvula that goes toward the unaffected side. Your patients may be drooling, severe throat, pain radiating to the ear. They can have a muffled voice and have a lot of difficulty swallowing. They can have difficulty breathing, bad breath, and they can have swollen lymph nodes on the affected side. Peritonsillar abscesses can be can be an emergency if they're left untreated. You can use an ultrasound or a CT for diagnosis. And these patients will need an antibiotic. Sometimes just oral antibiotics are not effective enough. A patient may need to be admitted to the hospital to have IV antibiotics, and then opioids for the severe pain that can cause that. If the airway is endangered, then again hospitalization is needed. And this is a picture of the peritonsillar abscess with the pus on that left side there, right close to the uvula. Laryngitis is, just like it says, an inflammation of the larynx. The patient can have acute hoarseness, a dry cough, a lot of difficulty swallowing, and a temporary voice loss, which is called aphonia. Treatment is basically focused on relief and prevention. You let the patient have voice rest, again, hot showers in the bathroom or humidification are really good for the passageways, increase their fluid intake to keep everything hydrated, throat lozenges, and also reduce the use of tobacco and alcohol. Influenza, or the flu, is a highly contagious, it's acute and viral respiratory infection. Severe headache, muscle ache, fever, chills, fatigue, weakness, and anorexia. We have had epidemics of flu in the past, and it can lead to a lot of complications of pneumonia or even death. Between 5 and 20% of the population develop influenza each year, and hospitalizations may be required for severe flu cases. The vaccination is advisable, especially to those patients or people with chronic disease processes such as hypertension, diabetes, COPD, CHF, and antivirals can be started within 24 to 48 hours of symptoms. The influenza or flu, most of those patients do not need antibiotics. It's basically treating the symptoms. The pandemic influenza is most prevalent among birds and animals. The virus can mutate, becoming infectious to humans. An example is the H1N1 swine flu, which we actually had a large epidemic several years back. These can spread globally, and it's also known as the bird flu. You want strict isolation precautions and antiviral drugs like Tamiflu and Relenza. Pneumonia. Pneumonia is excess fluid in our lungs resulting from the inflammatory process. The inflammatory process can be triggered by organisms in our bloodstream. It can also be triggered by irritating agents, again, smoking, things in the air. The inflammation occurs in your interstitial spaces, your alveoli, and often your bronchioles, which is why it can affect your gas exchange and your perfusion. Pneumonia starts when that specific organism penetrates into your nose and airway. It multiplies in your alveolar spaces. Your body senses that something is going on, so your white blood cells will migrate to that area of infection, and this causes capillary leaks, it causes swelling, it causes exudate, and then all of these fluids collect around the alveoli and your alveolar walls thicken. So as all of this is happening, that reduces your gas exchange. It can lead to hypoxemia, which interferes with your oxygen, and it can lead to death. If the organisms that are in your system move into the bloodstream, you can become septic. If the infection extends into your pleural cavity, that's the lining around your lungs, you can get empyema, which is a collection of pus in your pleural cavity. So pneumonia can be very serious. You can also get community-acquired and hospital-acquired pneumonia, which is called a nosocomial infection. So it's always good to use good hand washing techniques. Ventilator-associated pneumonia is pneumonia that patients get when they've been on a ventilator for a long period of time. It has become increasing in a hospital setting, especially when patients have endotracheal tubes in place. Good hand washing, oral care, and of course keeping the head of the bed elevated can keep this particular type of pneumonia at bay. Some of the laboratory testing: culture and sensitivity of the sputum with a gram stain, CBC to see if they have an infection, ABGs to see how your lungs are functioning, a serum BUN, which is an evaluation of your kidney functions, electrolytes, sodium, potassium, things along those lines, and your creatinine, which again is another indication of your kidney functions. Realize that pneumonia develops when your immune system can't overcome the organisms that are in your body. A patient who has a normal immune system most of the time can fight off those invading organisms, but patients who are immunocompromised, like those who have cancer, HIV patients, chronic COPD patients, cystic fibrosis patients, immune systems are chronically low. So when these organs go in there to invade, their body can't fight them off. Some risk factors for pneumonia: older adults, of course. Anybody who has never received the pneumococcal vaccine, and they usually recommend, I believe, the pneumococcal vaccine starting at 60 or 65. Patients who have not received the flu vaccine, anybody who has chronic health problems or coexisting conditions, again, hypertension, diabetes, if anybody who's been exposed recently to someone who's had a respiratory infection, or if they use tobacco or alcohol in high amounts. So some imaging, a chest x-ray can tell us how our lungs are functioning, and we can see areas of consolidation on the chest x-ray that will tell us whether it's pneumonia or not. A lot of times their pulse ox will be low because of the gas exchange and tissue perfusion is decreased. Transtracheal aspiration, which is where they have just aspirated into their tracheal trees. And then, of course, a bronchoscopy to take a look at the tissues and making sure that they do not have a infectious process going on there. Things we can do for patients who have pneumonia, especially when they get out of the hospital, is to make sure they have excellent education, that they know how to take their medications and the importance of taking their medications every single day. If they need oxygen, make sure they have oxygen at home. Make sure the things that are in the house, maybe a bedside commode, just everything that is in reach for that particular patient. Hopefully they will have some family support that can stay with them or at least come by and see them. The older the adult is, the longer the recovery phase is. It can be frustrating. They can have a lot of fatigue and weakness, and also have a residual cough that sometimes can last for weeks. So it's really important also to have a good support system and to have good nursing care for patients that have pneumonia. Of course, teaching for self-management, and then if any healthcare resources, again, home health nurses maybe to come out and visit to make sure the patient's doing okay. Prevention, make sure patients are getting that pneumonia vaccine and the influenza vaccine. And a couple of things to, again, remember about pneumonia is that patients a lot of times will be very hypotensive because of the vasodilation and the dehydration that is going on. They can have really rapid, weak pulses. They can be dehydrated. They can be septic. So watching their vital signs, watching their breathing, checking their lab results is going to be real important in your assessment process. Realize that your chest x-rays can take 2 to 3 days actually to show pneumonia up. So although that's an important assessment factor, sometimes it doesn't show up right in the very beginning part of the assessment process. Most of these patients are going to be on oxygen therapy or have incentive spirometers to try to help improve their muscle actions and their breathing, and also to help prevent atelectasis when those alveolar in your lungs collapse. SARS, or severe acute respiratory syndrome, is a respiratory infection. It's a relatively newer form. It's a family of viruses that causes many forms of the common cold. It is easily spread by airborne droplets, so if a patient was in the hospital, they would be on airborne precautions from affected people through sneezing, coughing, and talking. Those people who are at greatest risk are those who are, of course, in close contact with an infected person, like with your family member or your significant other. And it's easily contracted through the mucous membranes of the eyes, nose, and mouth. There's no known effective treatment. You must prevent the spread of infection, good hand washing, strict airborne isolation if these patients are in the hospital. And there's really not a lot at this point that we can do about it, except to, of course, have them in the hospital until things get better. You would want to wear eye protection and strict airborne and contact precautions with them. Pulmonary tuberculosis. Tuberculosis is highly communicable. It is caused by the Mycobacterium tuberculosis. It is one of the most common bacteria infections worldwide, and it is spread through the airborne route. Anytime a person coughs, laughs, whistles, or even sings, those droplets are airborne and they can be inhaled by others. Realize that a lot of people will actually get the bacillus part of the tuberculosis and never actually develop active TB. You can get a secondary TB. Secondary TB is just a reactivation of the disease in a previously infected person. It's kind of like having an infection and taking antibiotics and being okay for 2 or 3 weeks and then starting to get sick again. It's more likely to happen when a person whose immune system is lowered, such as in older adults or people with HIV disease, and your upper lobes of your lungs are the most common site of reactivation. Of course, there's an increased incidence that's secondary to the HIV infection, seeing as most of those people are immune compromised. So some things that we're going to see with TB, a progressive fatigue process. These patients may be lethargic, have, again, nausea, anorexia, weight loss. With women, you may see their periods are irregular, low-grade fever, night sweats, cough, a purulent sputum that's colored, and the sputum could have blood streaks in it. Detecting TB depends more on your subjective findings rather than on things that you can observe. It has a slow onset. A lot of times patients are not even aware that they have the disease till it's advanced. So anybody that has a persistent cough, the symptoms that we just mentioned here on slide 20 should be evaluated for tuberculosis, especially if patients have been out of the country or are elderly. Then we should start looking at TB as a diagnosis. So in our assessment process, we want to know, again, if the patient's been out of the country, if they've traveled to any foreign countries where the incidence of TB might be high, if they've been around anybody who they know has been previously tested positive for TB, or anyone who has received the vaccine, the BCG vaccine, within the previous 10 years can have a positive skin test that can complicate an interpretation. You can actually have false TB skin test. The physical assessment, the slide before again mentioned progressive fatigue that won't go away, nausea, anorexia, weight loss, irregular menses. They can have chest tightness, a dull, aching chest that occurs from the cough. So you just want to make sure that you're assessing all of these particular symptoms, and if you cannot find another cause and they fit the profile, then you would want to start testing for tuberculosis. So our diagnostic assessment, again, what our signs and symptoms are. An NAA test is a new test that's fully automatic. It can be run on a machine in the lab. It's called a nucleic acid amplification test. It is strictly for tuberculosis, and results are available in less than 2 hours. Again, we can do sputum specimens to check for acid-fast bacillus or AFB. Also one that checks for the Mycobacterium tuberculosis. You can do the PPD, which we're all familiar with, in the forearm, and any induration of greater than 10 millimeters is positive. This right here is a positive PPD test. So interventions to treat PPD, there's combination drug therapy here. I'm not going to try to pronounce all of those drugs, but it is a very expensive and combination that patients must have strict adherence to. They must take all of their medications every single day. The reason for all of the different types of drugs is so that it can destroy all of the organisms in the bloodstream as quickly as possible, and it also helps to reduce the history of drug-resistant organisms. So by using different medications, the organisms don't get used to just one medication. There is a chart on 597 that goes over every single drug listed here, how its purpose and action, and what we should teach the patient, as far as is nursing and the rationales for that. When the patient has a negative sputum culture, then they are no longer infectious. Most patients are managed outside the hospital. However, you may have patients that are diagnosed with TB while in the hospital, if they're in there for pneumonia or some other reason, and then their discharge may just be delayed. It's always good to communicate and collaborate with your case managers or your social services to make sure when this particular person gets out of the hospital that they have all the things that they will need at home, whether it's oxygen or medication, teaching for self-management on how to take care of themselves, or if they need other resources financially or economically, then they will have those particular resources when they get out of the hospital. These drugs, the particular drugs we discussed, have to be taken for at least 2 to 3 consecutive weeks before they are no longer contagious, and they have to be making improvements in their signs and symptoms. And they also must realize that they have to continue with these prescribed drugs for 6 months or longer to be considered cured. Things that we worry about are patients who have had weight loss. Then we want to make sure that we're getting them proper nutrition. They need to make sure they're having follow-up care. They need to be followed up for at least a year afterwards, and for any time during active treatment. Lung abscess. Abscesses are caused by areas of lung destruction. It can be caused from a history of pneumonia, aspiration, or any type of a tumor or foreign body. It's usually related to a bacteria that's already in the system. People can have a lot of pleuritic, that's like lung-type chest pain. Interventions for this are just antibiotics to help get rid of the infection, drainage of any large amounts of abscess, and then frequent mouth care for candida or yeast. the antibiotics can cause a lot of mouth ulcers and mouth issues, so we want to be frequently checking our patient's mouth. And the pleuritic chest pain is just a stabbing pain when your particular patient is taking a really good deep breath. These clients can be febrile, they can be pale, fatigued. You may have decreased breath sounds and a dullness on percussion where that abscess is. You may have bronchial breath sounds and crackles over the side of the lesion. And to diagnose this, you would need a chest x-ray, a sputum sample, and a CBC. TB testing should always be considered for patients at risk for lung abscesses. Inhalation anthrax. This is caused by the gram-positive bacteria Bacillus anthracis, and you see this a lot from contaminated soil, especially where cows and goats that eat grass, you see this a lot. Most cases of anthrax are on the skin. Inhalation anthrax only accounts for about 5% of the cases, and you have GI anthrax, which accounts for about 1% of the cases. When infection occurs through the lungs, the disease is 100% fatal without treatment, and this is a very rare occurrence here in North America. It's not spread by person, but it can be an occupational hazard with veterinarians and farmers and those along those aspects. Drug therapy to treat it is Cipro, doxycycline, and amoxicillin. You have two phases, the prodromal phase and your fulminant phase. The prodromal phase is just the first early phase. It's difficult to distinguish because you have a lot of signs and symptoms like you do with influenza or pneumonia. You can have a low-grade fever, fatigue, mild chest pain, and a dry, harsh cough. One of the features is it is not accompanied by upper respiratory things such as sore throat or rhinitis. The patient usually starts to feel better within about 2 to 4 days. The fulminant stage begins after your patient starts to feel a little bit better. They'll have a sudden onset of symptoms like bloody vomit, shortness of breath, severe sweating, chest pain, and cyanosis. The patient will also have a high fever. Pleural effusions can develop, and the patient may be needed to be admitted to the hospital to help manage these symptoms. Pulmonary empyema. This is a collection of pus in the pleural cavity around the lungs. Your most common causes are pulmonary infections, lung abscesses, and of course an infected pleural effusions. Chest surgery or any type of trauma can introduce bacteria into those pleural spaces, and that leads to the empyema. Blood from trauma can collect in those pleural spaces, and that helps promote infection. You can see febrile illness, pneumonia, chest pain, shortness of breath, cough, trauma. Things to document are the character of your sputum, whether it's thin or thick or green or clear. Your chest wall motion can be reduced. These patients really don't want to breathe fully for you. They have a lot of painful breathing. You may have fremitus present. Percussion is flat and your breath sounds are decreased. You can also have abnormal breath sounds to include bronchial breath sounds. The patient also can have fever, chills, night sweats, weight loss. For diagnosis, you want a chest x-ray or a CAT scan, and then a sample of that pleural fluid, which you will get through a thoracentesis. Empyema fluid is very thick. It's opaque, which means it's almost clear. It's exudative, and it's very foul smelling. Therapy to help get rid of the empyema means basically emptying out the cavity, re-expanding that lung and controlling the infection, which means antibiotics. This patient will have a chest tube to closed chest drainage to help that lung expand and drain, and then the chest tube is removed when the lung is fully expanded and the infection is under control. These patients may need chest surgery for the thick pus and the pleural thickening that causes in there. So this is the end of my lecture, and if you would like, you may go through and do the case studies.